So welcome everybody. My name is Jackie Hayden and I'm president of the Academy of Medical Educators, and I'm really thrilled to welcome you to our 5th event in the Insight series. Previous events have included education at the time of COVID and moving into professional education from the periphery to the core, and a reflective model for medical education, as well as the future of dental education. And those are available on our website if the titles sound interesting. So we very much welcome feedback on our Insight series and welcome your input from members or non-members on possible future topics. So keep an eye out on our website and in our newsletters. And if you follow us on Twitter, then you can find out more of what we have planned. So just to tell you a little bit about the Academy, for those of you who are new to us, and if you are new to us, I hope by the end of the evening you might think about joining us. So the Academy of Medical Educators was established in 2006. We're a charitable organisation which exists to advance medical education for the benefit of the public. It's the professional organisation for all those involved in the training and education of doctors, physician associates, dentists and veterinary surgeons. The Academy is the standard-setting body for medical educators in the UK, and our professional standards define the level of competence that medical educators should achieve at each point in their careers. The standards provide a recognised framework for professionals to demonstrate expertise in medical education through accreditation as a medical teacher. Recognition by the Academy demonstrates skills and competence when applying for revalidation, promotion, and as approval as a trainer. We're still relatively small in numbers, with just over 1,200 members, and we are based across the UK and beyond, with our office in Cardiff. And if you join us, you have access to a network of medical educators at every level of their career progression. We have regular newsletters, mailings and updates, and via an online community, and a programme of academic meetings and events, including the Insight series, which we are about to start, and our annual Coleman lecture. So today we're focusing on our neurodiverse learners, and we have a brilliant group of individuals who will help us understand how we can be more effective as educators working with a growing group of learners. I imagine that many of you have joined today because you or someone you know is neurodiverse, or you have found some of our neurodiverse learners immensely rewarding or possibly immensely challenging. Some of you may be exasperated by learners who are late with assignments or struggle to keep focus. Others may welcome the refreshing and challenging approach that the same learners bring. So we hope by the end of the evening, you'll have a little bit more insight in how we can all be more effective. It's essential that we are sensitive to all our learners' needs, and the recent GMC publication on variable progression has highlighted the gap in achievement in doctors who have a disability. Many of those with disabilities will include the group that we're focusing on today. So let me introduce our panel. Our chair this evening is Dr. Sebastian Shaw, who is a lecturer in medical education in the Department of Medical Education in Brighton and Sussex Medical School. Seb is multiply neurodivergent, formerly diagnosed as autistic, ADHD, and dyslexic. He's a lecturer in medical education at Brighton and Sussex Medical School and is the research lead for Autistic Doctors International. His PhD was focused on supporting neurodivergent medical students and junior doctors. His research interests centre around social justice, epistemic empowerment, improving medical education for neurodivergent people, and improving healthcare access for the wider neurodivergent communities. Joining him are Dr. Alex Connor, Dr. Rachel Major, and Dr. Mary Doherty. Seb will explain how the evening will run in more detail. I just want to remind you that there will be plenty of opportunity to ask questions through the Q&A. If you can post them on the Q&A rather than the chat, we'll keep an eye on them and we'll field them, and then you can contribute to the debate. And finally, just a matter of hygiene, can you make sure that your microphones are turned off and that you can keep your camera on if you like, but you may want to turn it off to just keep the bandwidth safe. So without more ado, I'm going to hand over to Seb.
Thanks, Jackie. Let me just share my screen before I forget. So there we go. So again, thank you, Jackie. And it's really lovely to see the Academy starting to really champion this area as well. So I personally have been a member of the Academy for about 8 years now, and it's really validating actually to be asked to come and help with this. And also welcome to everyone who's taken the time out of their day to attend today. So it's not letting me change slide. That's always good. There we go. So I'm just going to go into a bit more depth to begin with to help introduce our wonderful panelists tonight. So you've heard about me, so we can ignore me off on the left. So I'm presenting people here purely in the order that we're going to be running in tonight. So firstly, we have Dr. Alex Connor. Alex is a consultant in ADHD support and education. He was the director of taught postgraduate education and a reader in biomedical science education at the University of Birmingham Medical School until last year, when he lost concentration, moved to Bavaria and accidentally became a full-time ADHD consultant and coach. Alex won a national teaching fellowship in 2021 for a non-directive coaching approach to teaching technical medical education. He's the chair of the charity ADHD Adult UK, advocating and supporting for adults with ADHD. He also co-hosts the most popular ADHD podcast in the UK, The ADHD Adults, with Professor James Brown. And Alex gives talks and writes articles on ADHD, including for the THES, The Independent, Medical News Today. And Alex has ADHD and was diagnosed as an adult. And I just want to extend a particular thanks to Alex for stepping in and helping with the panel session today at very short notice, and we really are very grateful. So next we have Dr. Rachel Major. So Rachel has been a lecturer/senior lecturer for the past 21 years, leading on both pre and post-registration programs at the Institute of Health and Social Care Studies in Guernsey, where she is also the Equality, Diversity and Inclusion Lead. She's passionate about supporting inclusion within nursing, and she completed a doctorate in education, investigating the experiences of registered nurses with dyslexia in 2017. Since then, she's been involved in the support of students with a range of disabilities and has conducted further research into the experiences of neurodivergent nurses. She led the development of new guidance and resources for the Royal College of Nursing to support neurodiversity in nursing. And last but not least, Dr. Mary Doherty. So Mary is an Irish anaesthetist who has received her autism diagnosis in adulthood. She became interested in barriers affecting autistic people's access to healthcare in 2018, starting her work on this topic by a consultation with the community at the autistic-led conference Autscape, followed by an online survey. The results of this work have been published in the British Medical Journal Open last year. After coming out publicly as an autistic doctor, Dr. Doherty started connecting with other autistic medical doctors, and in 2019 she founded Autistic Doctors International, originally as an advocacy and peer support group with 7 members. In 2023, this group connects nearly 700 autistic doctors from around the world, and ADI has added research and education to its original areas of action, while continuing to provide a safe space and peer support to its members. So a big welcome and big thank you to all of our panel members coming in today. Just to touch on the formats that we'll be going through. So we've done introductions. I will then take you through a very brief overview of neurodiversity as a concept to help conceptualize things. And we'll then run into a series of 4 individual talks lasting about 10 to 15 minutes each. I will be starting, followed by Alex, then Rachel, and then Mary. And the talks have a really nice span from more conceptual, broad, deep thinking, down into some research finding presentation, and also down to some on-the-ground reasonable adjustments frameworks that can be helpful for supporting neurodivergent students. After the talks, we'll have a short break, and then we'll run into a panel session where we'll answer people's questions. And the Academy have kindly agreed to support me there by taking over and reading questions for us. So, Jackie's already mentioned some of this, but a little bit of housekeeping. So please do feel free to ask questions. Try to post them in the Q&A function, if you remember. So that's where questions will be extracted from rather than the chat. When I looked at the box earlier, it was a few buttons to the right of the chat function. And we won't pause for questions between each individual talk in the interest of time, particularly with our slightly late start following the IT mishap. But what we'll do is we will go through them at the end as the panel discussion. So please do feel free to pop things in the Q&A chat and the Q&A function as and when you think of questions. So some opening notes on neurodiversity first to help set the scene. I want to start with just a little bit on terminology, you know, much like Heinz, there will be 57 varieties, if not many more in this instance. So I am drawing on the terminology promoted by Nick Walker in her Neuroqueer blog, which I think a lot of us in neurodivergent academia use. So based on this terminology, we would say that society is neurodiverse. There's lots of different neurotypes, you know, we're all a bit different. And then within society, we have neurodivergent people and neurotypical people. And using this approach, we would describe a neurodivergent person as neurodivergent rather than neurodiverse. We would say neurodiverse is a societal measure of lots of different neurotypes. And then different types of neurodivergence, such as autistic people or ADHD people, are minority neurotypes, or sometimes you'll see people say neurominorities. And then people like me who have generally quite spicy neurotypes, as me being autistic, ADHD, and dyslexic, as far as I know so far, we're usually referred to as multiply neurodivergent. And that's just a little picture on the right of the screen to kind of show a visual representation of that. But the big question lots of people ask at this point is, okay, we talked about kind of what we should say, how we should say it, but what kind of things come under this neurodivergence umbrella? And you've got the obvious, you know, most people when they talk about neurodivergence or neurodiversity as a broader concept, think about autism, ADHD, dyslexia, dyspraxia, dyscalculia, dysgraphia, and Tourette's. However, hard boundaries kind of defeat the point. What I'm getting at here is that, you know, neurodiversity is all about promoting inclusivity, you know, broad inclusion, and we don't want to make inclusion an exclusive club. So hard boundaries somewhat defeat the point, but these are certainly the neurotypes that most commonly are discussed in relation to this. But there are people out there advocating actually that, you know, why don't we include broader psychiatric labels in this? They're fluctuant, they change between iterations of DSM and ICD, and they're inherently socially constructed. We label it that name because someone once said that was a thing. So there are certainly advocates out there advocating for that change as well. So in answer to what counts, there isn't really an answer. We have a core group of neurotypes that we tend to talk about, but by no means should the concept be thought of as an exclusive club. All right, so we've talked about kind of what comes under neurodiversity and some words, but what is it? So we tend to say there's three different things. We have the fact, we're all neurologically diverse, biologically speaking. You know, our brains are not the same. If you put us all in a scanner, there will be subtle differences. That's not what most people are talking about when they think of neurodiversity. We've got the movement. So that's the group of neurodivergent advocates advocating from a human rights perspective, born out of the critical disability studies movement. So this is really, you know, the group of amazing advocates promoting change on the ground. Is this what people mean when they say neurodiversity? Yeah, sometimes. But there is another area as well. And I think the last area is often what people tend to conflate with the movement when they think of neurodiversity. And this is the neurodiversity paradigm. Anyone here from an academic med-ed background will probably be familiar with the term paradigm from research methodology. So a paradigm referring to a philosophical set of beliefs about what is reality and what is knowledge, or if we've accepted one belief about reality, what's the best way of knowing about it or making new knowledge about that. So that's what the neurodiversity paradigm is. It's a set of beliefs about what is real, and it challenges the traditional disorder and deficit-based view, instead promoting the idea around differences. And it argues that strengths and challenges are contextual. They're not inherently related to some flaw in the individual or the person in question. Contextual things could be timing. Catch me at a bad moment, I will certainly appear somewhat more stereotypical than in a good moment. But things like environment, and then more broadly, culture, social settings, and then more powerfully, things like politics and historical concepts that change how we view disability and neurodivergence in general. So the neurodiversity paradigm argues against disorder, but at the same time, it does not promote superpowers, which bring a whole other host of challenges as a narrative in the way that they can be hard to relate to, can be excluding, and can undermine the neurodiversity paradigm more broadly to create wider systemic harms in that sense. Neurodiversity doesn't argue against disablement. It shifts consideration to those external causes we talked about, and it doesn't negate support needs. Instead, it moves away from the idea of high functioning, low functioning, and these labels that very much provide a two-dimensional view of an individual person, not allowing for contextualization or change. So they very much promote adjustments in the concepts of support needs rather than individual functioning. And as an example, just to close off the introduction here, I hope no one's feeling like this. I apologize if you are. I use this to highlight a specific example. So I want to talk about ADHD. And I want this to be an example of something that outlines context, really. So most of us ADHD folks tend to struggle with sleep. It's really, really common for us to be up a lot of times during the night, very, very short, sharp bouts of sleep. In the concept of a 9 till 5, then trying to go in and run a clinic for me, or for someone else run a ward round if they're in secondary care, pretty disabling to have not had a lot of sleep. However, if we think back to more tribal-based communities, let's say where there were predatory threats from lions, for example, overnight, which tribe is most likely to survive? The tribe where everyone is neurotypical and sound asleep, or the tribe that has more ADHD folks who are more likely to be constantly awake and therefore more likely to spot danger? And I think this is a good example of showing how something that could have been a really strong evolutionary advantage has become disabling in the modern context through the social construct of the 9 till 5 and needing to sleep in a certain way in a certain period of time. So on to our talks. And again, if anyone has any questions from that first part or throughout, please just pop them in the Q&A and we will happily come to them in the panel session. So, first talk, I'm afraid, is from me. I promise you'll be rid of me soon. I will be talking about autism and weaponized professionalism in medical education. I'm using autism as an example here because there's essentially the data exists to be able to support it, where the research hasn't been done necessarily in other neurotypes. And I'll be looking at weaponized professionalism and also bringing in some of the things that we can do to help combat this, including neurodivergent role modeling. So I do have some trigger warnings for this session, and I think it's important that I mention these here, just in case anyone does feel they might be triggered by these. Please do feel free to mute me, turn me off for 10 minutes, go and make a cup of tea. But I want to be clear here that these things will come up. So I will be touching on mental health, which will include suicidal thoughts and attempts and self-harm. I'll be talking about the weaponization of professionalism. I'll be talking about stereotypes and about autistic masking. So There we go. So as the Medical Schools Council have said in their active inclusion guidance, published not this December just gone, but the one before, the pandemic has brought systematic and social issues to the fore. It's caused us to question, both as people and as leaders, what more can be done to support and champion greater inclusion and diversity. And as the BMA say, and the GMC in their welcome and valued guidance, by supporting widening participation in medicine, we're also ensuring that the NHS is reflective and understanding of the needs of its patients in the future. And neurodivergence is a fab example of this. We intuitively get one another. We know we communicate in a different, not less, in a different way to neurotypical people. So having more of us neurodivergent folks in the workforce is a very obvious benefit to the barriers to healthcare access faced by neurodivergent patients in the community. But it's all well and good saying that we need to recruit more of a diverse workforce. But I think all of us here will be aware that truly championing diversity is more than just bums on seats. So what's happening? So this is a study at Mary's and mine, actually. So it's a cross-sectional survey looking at the experience of 225 autistic doctors. There's some fairly shocking results. If I'm honest. 77% had considered suicide and 24% had attempted suicide. And the thing that really struck me here is that this will only pick up the people with unsuccessful attempts. And half had engaged in self-harm. And these are quite shocking figures, even when compared to the wider autistic community and to the wider medical workforce. 20% had never worked with another doctor that they thought might be autistic. And that was actually associated with considering suicide. So whether there's some mediation there around isolation feelings. 64% preferred the term autistic doctors, so identity first language, and that's in preference over person first language, such as doctor with autism or something like doctor on the spectrum. And 83% considered autism to be a difference, so in keeping with the neurodiversity paradigm. The most striking finding here to me was that when participants considered autism to be a disorder, i.e. they'd very much been indoctrinated into that medical model that we're all trained in, this was actually associated for both a preference for person-first language, doctors with autism, and it was also associated with having attempted suicide. So there was something about having internalized this medicalized view of autism being a disorder that was associated with suicide attempts in this sample. So quite striking. But what's going wrong? We're recruiting diversity and then we're seeing the shocking, or perhaps not shocking to some of us, outcomes. What's happening? And now I want to talk about professionalism and weaponization of professionalism. And I'm going to use a couple of quotes to do that. So medical professionalism is espoused as a necessity in healthcare, setting an important precedent of excellence and respect towards peers and patients. In many medical schools, a portion of the curriculum is dedicated to the intricacies of medical professionalism. Though typically taught through the specific tenets and case studies, professionalism is still a general principle, resulting in varied definitions across institutions. And that is, in fact, part of the beauty of professionalism. The lack of definition makes it a flexible concept and therefore applicable in a wide variety of situations. So, yeah, that's professionalism. But what happens when we start to weaponize it or to argue that there is one right way of being professional? So the downside of this vagary is that it allows for the weaponization of professionalism, leaving space for professionals to reject certain approaches to healthcare. And further, since the concept of medical professionalism itself was devised by and upholds the tradition of the most powerful voices in the field, i.e. cisgendered white males, usually from higher socioeconomic classes, this weaponization can damage the diversity of appearances, mannerisms, and it can damage proposed changes to healthcare administration for minority groups in medicine. And so therefore, instead of being used flexibly, it is possible for professionalism to be twisted to keep medicine rigid and conforming to the standards of the powerful. And whether or not this is necessarily happening in a conscious way, this is something that medical students report worrying about and fearing. So why autism specifically? So there's a concept around autism called the tragedy narrative. And it's this idea that it's seen as a tragedy to just be who we are, i.e. when a child, for example, receives an autism diagnosis, often there's an associated grieving process, as if there's the loss of a non-autistic child that parents expected their child to become. And I'm using a quote here from Jim Sinclair, a famous advocate, and this was read out in the kind of early to mid 90s. And it holds true today to really evidence some of this. So he said, autism isn't something a person has, or a shell that a person is trapped inside. Autism is a way of being. It's pervasive. It colours every experience, every sensation, perception, thought, emotion, and encounter, every aspect of existence. It's not possible to separate autism from the person. And if it were, the person you'd have left would not be the same person you started with. And I think this really helps to evidence that we don't necessarily feel that our existence is a tragedy, but that neurotypically autism is often seen that way. And then we have diagnostic criteria, particularly a risk to our medical students around things like moral injury. So neurodivergence was, as we all know, traditionally framed under a medical model. Diagnostic criteria frame what we might now think of difference being contextually disabled. They framed this as disorder and deficit without recognizing the external factors, essentially. And then unopposed, continuing to educate our medical students in particular, but also our trainees, on these criteria or these deficits. It risks emotional and psychological injury to neurodivergent students and trainees who may be sat, unknowing to the educators, may be sat in these lectures hearing about all the ways that they're supposedly disordered. And then, of course, there is the moral injury component. If they deeply internalize this and then feel they have to pass this on to their own neurodivergent patients in future. However, as we've said before, diagnostic criteria are socially constructed, they're ever-changing, and whilst they currently reinforce stereotypes, that may not necessarily always be the case. And in comparison to stereotypes, particularly misunderstandings in the GMC's outcomes for graduates framework, I think that is a really core thing that I found when speaking to autistic students that worries them. This idea that they've sat in lecture theatres and been told all the ways they're disordered around communication, empathy, and all of these quite outdated stereotypes. And then in the next lecture, maybe a professionalism lecture around the communication skills and empathy requirements of graduates. So if not combated, it can feel a little bit like a bit of an oxymoron there to put those two together. And that can be quite damaging for students to sit through, particularly neurodivergent students. And there's just a tiny case study here that I've pulled from an article that Mary previously published. And this was the outcome of an ARCP, or an annual review of competencies panel, for a general practice trainee who was autistic. The panel regrets to learn of your recent diagnosis of autism spectrum disorder. But since this is a lifelong developmental syndrome which causes permanent impairment of many of the competences required for independent practice as a GP, the panel cannot see how any workplace adaptations could now be put in place to successfully alter your outcome. This is not too long ago, I will say, and I think it's quite telling about the way that stereotype and rigid misapplication of diagnostic criteria and guidelines still happens and can be quite damaging. This was overturned. So we're nearing the end of my talk now. I just want to tie in something called autistic masking. So masking is where we consciously act in a way that makes ourselves appear not autistic. Think, for anyone in here who's not autistic or not neurodivergent, think of it like being in a constant OSCE, a constant simulation or role play, analysing situations, working out, so do I need to say it this way or that way, and constantly thinking about how to best communicate in a non-natural way so that we fly under the radar. And those of us who have the ability to do this can and often do use it to appear to not be autistic, but it comes with a really massive cost. It's exhausting, both physically and emotionally. And it promotes negative self-concept and low self-esteem. If we constantly try to pass as something we're not, it can be really deeply wounding to our sense of self and self-concept. And studies have shown actually that in autistic adults outside of medicine, that actually masking behaviors are a major risk factor for suicide. Masking can also be called camouflaging, if anyone's come across that. And it's just a quote here from Maya Angelou to say, there is no greater agony than bearing an untold story inside you. And a thought for reflection: could masking, due to fear of weaponized professionalism and the other consequences of being their true, authentically neurodivergent selves, relate in some way to that 77% prevalence of suicidal ideation in autistic doctors? And to close off, I'm going to take you through one possible way that we as a broad workforce and broadly medical educationalists can combat this. And that's neurodivergent role modeling. So society teaches neurodivergent people subconsciously through microaggressions and more broadly through systemic ableism to feel a bit othered, a bit lesser and marginalized. And if we internalize that, we can end up feeling quite broken or unworthy. And then if we enter medical education, and then we see this focus on disorder and deficit around neurodivergence, that risks us starting to question our suitability within medicine, particularly, as I said, if that's then combined with rigid misapplication of GMC's outcomes for graduates. Fearing weaponization of professionalism subsequently may drive us into masking and hiding who we are. And, you know, the negative mental health outcomes from masking, they extend beyond suicide, more broadly, particularly around autistic burnout. And that really risks losing the diversity within the workforce. And that's a loss to the workforce, and it's a loss to the neurodivergent people leaving, but it's also a massive loss to the neurodivergent patients who would have benefited from that diversity. But positive role modeling can help. We need more neurodivergent people to come out in times of success to help challenge that tragedy narrative that's so deeply embedded, particularly when coming out is often taken out of people's hands and is forced in times of struggles and challenges through unrecognized neurodivergence or unsupported neurodivergence. So having more positive neurodivergent role models may help in the longer term to change this culture and to show our neurodivergent students or trainees that they can't just survive, but they can also thrive within medicine, and to give them that confidence to advocate for the adjustments they need to keep their skills in the profession. So in summary, neurodivergence brings some strengths, which very much be a benefit to the medical workforce and our patients, but strengths and challenges are so contextual. And there are many ways to be professional, and that is reflective of the beautiful diversity, not just neurodiversity, but more broadly across our entire workforce. And weaponized professionalism or fear of weaponized professionalism may promote masking, and masking is known to be a major risk factor for suicide. And somewhat confirming potentially some of this through association were the high rates of suicide and self-harm reported in a recent study of autistic doctors. Our language matters, also tied in with those studies, so difference over disorder, but does not refute disablement or support needs. And we should be affirming how each individual person wishes to identify themselves. And lastly, role modeling can help. We need to start, as the title of the webinar says, embracing neurodiversity in our medical educators to help provide that confidence and more positive experience to our students and trainees than many of us went through all the time. So, as I said, please do pop questions in the Q&A. We won't actually pause here for questions, but we'll go through them in the panel discussion at the end. So thank you for listening to my session. I will stop sharing my screen there. So now, Alex, are you happy to come on and share yours, if that's okay?
Absolutely. Can you hear me okay?
Thank you.
Thanks for that, Sebastian. That was really helpful. Right, I'm going to share screen. And can you see a regular PowerPoint, or do you see something weird?
Alex, you're on presenter mode.
I thought so. It's because I had a spare screen stuck in. What about, no, let me get rid of that then. How about that?
That's fab. Thanks.
Lovely. Thank you very much for that, and thank you ever so much for inviting me to speak. If you're expecting the lovely Professor James Brown, he's not very well. He's in a bipolar low actually at the moment, which he has every so often, and we talk about it. We talk about it when I am, when he is, and because that's often comes with ADHD, annoyingly. We used to say we had a cold or something, but we don't anymore. If you can come out, as Sebastian said, it isn't easy, and I would urge you to do that if you have social power. If you don't. It's definitely a personal decision, but it can, especially in times of success, super helpful. I've been asked to talk to you about a little bit about ADHD and how we can improve education support. I've got a few tips for you. My dog's going a bit bonkers. I'm in a funny old knowledge equity position. I very much was. I taught medicine at pre-clin for a long time. I have ADHD. I was diagnosed as an adult, as you said, and I'm now a private consultant working in the education sector, in private education, in mental health support, coaching, and other kinds of trainings. For example, primary care, CPD, and all sorts of things. In a nutshell, I've got lots going on around with children and childcare and the dog shouting at me, so I apologize. It's very distracting, which isn't very helpful for my brain. 1 second. I'm going to shut the door. Right then, I thought I'd just talk to you a little bit about ADHD. We feel sometimes in the ADHD world, because I'm chair of a little charity, please come and have a chat if you want to discuss ADHD at any level, really. We do adult ADHD. We sometimes feel like the poor cousin, because when people talk about neurodiversity, they tend to talk about autism and maybe sometimes specific learning disorders and so on. ADHD often gets left behind a little bit, and we think that that's to do with some of the myths and stereotypes that go along with it, which is another reason we set up the organization to help. So ADHD is a lifelong neurodevelopmental disorder, or just, so I'm really sorry about that, Sebastian, the word disorder is being used here, or deficit if you prefer, but to like the whole world, deficit means a lack, but in the science community where no one really lives, it doesn't. It can also mean it doesn't work properly. ADHD is a rubbish name. Attention deficit hyperactivity disorder. Many people, especially across gender lines, the hyperactivity is internalized or not there at all, and it isn't a lack of attention. Rather, we don't focus on the things we want to, or we don't easily get to choose what to focus on or for how long. Easily distracted. There's more than one flavor of ADHD itself. We don't entirely know the causes of ADHD, certainly a combination of genetics and environment. Unlikely that anyone's purely genetic ADHD. I would have thought certainly not one gene, might be one or two, but unlikely. But it is about 80% hereditary. So there's a huge genetic component. Environmental triggers, however, are still up for grabs. The flavors within that, there's neurodiversity within ADHD, so nobody's the same. But broadly speaking, we can split into 3 flavors. About a third of people are what we call inattentive type. About 2/3, including me, combined type, which combines inattention, and then the very small number of people are hyperactive impulsive type. Most of us sit in the middle, which makes my Venn diagram a bit rubbish, really, doesn't it? Because it's the middle bit small. We combine hyperactivity and impulsivity because they're like the handbrake of the brain, aren't they? If you can't physically stop yourself or mentally stop yourself from thinking something, it's an inhibition issue. That's what it is. I would never read this slide in a million years. I don't want you to. I want to do a magic trick for you, really. On the left, these are the inattentive symptoms that are diagnostic criteria for inattentive, and on the right, it's hyperactive impulsive. Don't read them, please. All I want you to do is choose any single one of these 18 at random and ask yourself, would that one be a hindrance to a learner at university? I mean, I reckon you just pick the one that is a hindrance, right? I mean, this is the issue right here. to get a diagnosis is really, really difficult of ADHD, not easy. Like, you know, in the Daily Telegraph, I think you need 5 out of 9 of these, and in more than one environment in your life. You've always had to have had them since being a young child. It's got to have a negative effect on your life, and it has to be not explicable by another psychiatric condition. Not simple, and the waiting list is blooming nightmare. Oh, that was me asking you that question. What's frustrating is, as a coach and a person that works a lot with adults with ADHD, is the vast majority of the problems we associate with our ADHD, me included, aren't typically those diagnostic criteria. They're what psychiatrists would call coexisting conditions that come with it, that our organization would call, this is ADHD, for the love of God. It's the higher order planning and organizing functions and the emotional side of things. So we are emotionally dysregulated as well. And we have a serious rejection sensitivity. It's kind of like being slapped with them when you've got emotional sunburn compared to when you haven't. So if you don't like this, you've got to tell me in a nice way. The higher ordered functions, I've got a load of them here. Things, I mean, for any student, let alone someone studying medicine, this is, you know, short-term memory, flexible thinking. If you've got a path to do something, but that doesn't work and you've got to hop onto a different path, swapping that is not simple for us. Effective decisions. If I drop a towel on the floor and I don't see no short-term emotional reward for picking it up, I'm paralyzed. It's not that I don't want to do it. Think about this from a student perspective. I can't do it. Do I pick it up or do I just leave it there? Do I pick it up or do I leave it there? I cannot make an effective decision in that context. We also are very short-term in many ways. So we have delay discounting. The further away in time something is, the less likely we are to do it, or our brains to want to do it, because of the nature of short-term reward systems. And then there's other things like time blindness, so we don't perceive time very well. The passing of time, we can't anticipate time. Brilliantly, I use a lot of exit timers and a lot of other maskings. I mask really well, trying not to do it quite so much. There's ADHD masking as well, as Sebastian talked about, autism masking. You may notice I move around a lot and I move my hair. Everything moves all the time. My feet. There's an innate physical hyperactivity in my presentation. Not everybody does that, but some of us do it a lot. Sitting still, therefore, in a lecture is physically painful. It's physically painful. Is it necessary for me to learn that thing? Do you need me to do that? You know, because I can. It hurts. You're asking me, you know, to choose. Just briefly, I'm medication hesitant. I don't like it. I'm also the CEO of a small drug company, which is ironic, I believe. I also take lisdexamfetamine speed every single goddamn day, not from local drug dealer, but I take Alvance because I have to. I don't like it. I'm a hippie. No drug is safe. We know that. Luckily, the medication, the stimulant medication for ADHD, is relatively well handled by our bodies and relatively safe. No drug is safe. But actually, it only really improves the core symptoms of ADHD, very few of the coexisting conditions. And many people can't take the medication or don't want to take the medication for ADHD. And talking therapies are recommended, CBT, coaching, and lots of other things in combination, because they are more helpful for the coexisting conditions, which I would call like the actual problems we have. So from that perspective, it's really tailored to the individual, like everything with ADHD, incredibly individualized. Right. We're less likely to get into HE, we're less likely to do very well, we're more likely to drop out, and we're less likely to get grades concomitant with our intellectual potential. That's what all that says. Unless the barriers are removed, and then we're all right. But you have to know what the barriers are, and no one asks. So ADHD is not a specific learning difference. If you think it is, I will challenge you with this one question. What specifically is it that I can't learn then? What is that? There are learning problems associated with ADHD, most of them structural in how we're expected to learn and respond in exams. They're often not concomitant with the learning objectives of the course in my experience as a medical educator. Most people with ADHD don't take the medicine because we don't remember to, because of the thing. And we often don't, more than half of us don't access, even when diagnosed, the provision that universities provide for us to support us. And most of the reason for that is it isn't fit for purpose. Just think about what my brain is like. I sit here and it's physically painful to sit for extra time. When I give a talk, which I do often to rooms full of people, adults with ADHD, and I say, do you know what they offer? Extra time in exams. Everyone laughs, everyone. Because it's like the last thing I need, the last. Oh, good, an extra 20 minutes to feel bad about myself. What would help is a break or a different way of expressing myself. Is that the only way you can think of or is necessary to demonstrate that I understand that topic, would be my question. There are loads of other reasons as well. The reasons for this are because there isn't a lot of education. This is a relatively new concept, adult ADHD. Annoyingly, there's evidence that it was around 250 years ago, but there's also evidence that it was around BC, and of course it was. But as something that needs supporting because of the burden of ADHD, really, really incredibly new. When I was diagnosed with hyperkinetic disorder because it wasn't, they weren't sure, so they changed it later on. And also there's not a lot of evidence for the support, what works and what doesn't. There is some evidence that extra time in exams specifically doesn't work, but there's evidence for lots of things that do. Text-to-speech software, changes in the environment, changes in the nature of the questions themselves. The issue is accessing those things and agreeing a reasonable adjustment requires the kinds of executive function planning that we haven't got in abundance. So we have to save it for when we really, really need it. And if you're doing a medical degree, there's a lot of planning goes into that. So we tend not to access that in the first place. The current support, as I've said, is one size fits all. This doesn't work in general. I mean, that's the spoiler here, is if you want to know how to support someone with ADHD, ask them. If you want to know how to support ADHD and HE, support your staff. That's what universities can do. If they really want to help, they should start with the staff, and the staff will support the students. That's what's missing. If somebody from starts in Freshers Week and they're doing a 3-year degree, it is very likely that by the time they want a titrated stable dose of ADHD medication, they will have graduated already because the waiting list is so long. So if you want a couple of examples, some people like it. Printed material helps. I know the environmental effects of that, and I know that universities don't like it. But if we want to remove structural barriers, that is something that helps. It does. It's as simple as that. ADHD does not have to be a barrier to success at all. There is an argument for the deficit model and the disorder and the medicalized model. For ADHD specifically, it's the one neurodivergent condition where there are measurable challenges that aren't really an advantage. The idea of strengths is relatively been dismissed now from a biological perspective. Strengths in ADHD tend to be learned strengths from living with barriers and challenges, in the same way that you wouldn't say to somebody in a wheelchair, well, you're kind of lucky because you have big arms. You know, that's an advantage of being in a wheelchair. It's not, of course. It's a learned skill that you've had to develop from not being able to walk. It seems to be more like that with ADHD. We're not more creative. We're not quicker thinkers. All of that's just a myth. The other issue is, of course, in any medical education and in healthcare in general, disclosure fears over fitness to practice are fundamentally terrifying. And this is why what Sebastian said about representation with success, representation, if you have social power, it's just fundamentally important. It's not very easy for anyone, we think, to do that. So please get in touch with us if that's something you want to approach. We'll talk to you about some of the words you can use and some of the challenges. So really, educating the wider community. This is a self-fulfilling group a bit because you've come to choose to listen to Neurodiversity. talks. It's the people that won't that we really, really need to get in a room. And as Sebastian's already said, the deprioritization of ADHD, both in education and at the moment in the NHS, is often because of all of these cultural and structural barriers across the system and funding. So really, better education, that's what we need. It's a neurological disorder. It isn't society's fault that I can't sit with my family all evening and enjoy their company, that even though I love them. It's the blooming thing. There are structural problems that make it worse, though. Support without diagnosis, please campaign for this within your universities. The diagnosis can take ages, as I've just said. So what could we help you with would be a brilliant thing from day one, regardless of diagnostic level, because you don't get free sweets. Teaching and support take into account problems with higher order planning. If it isn't a fundamental requirement and learning objective of that module, would be brilliant if possible. And to enable and empower staff with ADHD to understand that and to come out and again, talk to us. So, and the last thing really is that very few people with ADHD only have that. The coexisting conditions are rife, the comorbidities. And so everything has to be individualized, and taking that into account also really has to help. And this comes through discussion. If you want any more, I know I only got 50 minutes. I'm sorry if I went over. Please get in touch anywhere. There's all sorts of resources we have available through our charity and individually. Please come and chat. We love to talk everything adult ADHD. Thank you very much.
Thanks, Alex. And also really good to have representation of the different beliefs to mine actually in the panel as well. So I know we don't feel the same way about, I do still feel very social model for ADHD as well, but it's really a strength that we can actually have both representations here. So thank you so much for that.
I do a bit. I just feel I should add, just not entirely.
Yeah, no, and everyone is very much empowered to feel the way they feel. That's by virtue of what a paradigm is. It's our beliefs. So thank you so much for that talk. I wonder, Rachel, if I could please invite you to come on and give your talk now.
Thank you, Seb. Just bear with me while I share my screen. Okay, can you see my screen there? Okay, thank you very, very much for asking me to come and talk here. I'd just like to share a little bit of research that I've done on the effects of neurodivergence in nursing. If I can get it to move, that is. There we go. So the study was a pragmatic mixed method study. It was an online survey conducted over 3 months. And when I first started looking at doing this, I was expecting sort of 50 to 100 people. I got a response back of 657 respondents, which basically says something about the number of nurses that are neurodivergent out there. I then went on to do 16 in-depth narrative interviews, so 7 registered nurses, 6 students, 2 trainee nursing associates. So for those who are not aware of the sort of nursing structure, we have a slightly shorter course, a 2-year course with lower entry requirements. So if you go back far enough, it's similar to an enrolled nurse. So 2 that were training to do that, and 1 that had become a registered nursing associate. This is something that's only available in England. And those participants were aged between 20 and 49. So just a quick breakdown of the respondents. So I had 44.6% of student nurses, 42% of registered nurses, and a small number of nursing associates and training nursing associates. 89.9% identified as female, 9.3% as male, and the respondents came from across the whole of the UK and Crown dependencies. So Alex was talking about the fact that often people with ADHD have co-occurrences. What this showed me that actually a lot of people had co-occurrences. As you can see there, we've got ADHD, dyslexia, DCD or dyspraxia, autism, dyscalculia, Erlin's or visual stress, and other conditions. 71% identified as having just one area of neurodivergence, 1% identified as having 4 areas of neurodivergence. That's the most common was dyslexia, but what I think is that actually that's the easiest one to get diagnosed. And when I went to look at the group and my participants who were doing interviews, 3 had 1 area of neurodivergence, 6 had 2, 4 had 3, and 3 had 4 or more. But when you actually looked at their interviews, lots of them, even if they're identified as just having 1 area of neurodivergent, talked about problems and difficulties in areas that would have been perhaps more associated with a different area of neurodiversity, particularly around maths and attention difficulties. So the highest academic qualification obtained within the survey, we had, as shown there on that diagram, and we had a couple there with PhDs as well. Within the interviewees, we had anything from the access course to master's level qualifications. So one of the questions I asked was how much that they felt their neurodivergence affected their career progression, with 1 being not at all to about 5 being to a very large extent. And you can see that 26.2% identified that felt that it didn't really affect them. The rest of the cohort felt that it did, at least to a certain degree. The things that people identified as to why they felt their careers were affected was lack of confidence. So I had 1 participant who was a PhD graduate who was identified as being neurodivergent during their PhD studies, and that then stopped them going back into clinical practice. They felt that they lost confidence to return to clinical practice because they were worried about errors around medication administration. Things like not being able to perform effectively in interviews, lack of exams and academic success. So for some, it took them much longer to actually get into onto courses into nursing, or it prevented them from progressing because they didn't take higher levels of academic qualification. Bullying was mentioned on a number of occasions. They felt that it was hard to be taken seriously, and they felt also that they sometimes had to move to other areas of practice where they felt more comfortable, and that there was a high level of understanding, and that sometimes affected their career progression as well. So one of the things that came across was I asked whether or not there were times when their neurodivergence was affected more, and it was really when they were stressed, when they were tired, on long days, on night shifts, were the things that came up. And we know that stress and tiredness affect working memory. Also, participants discussed how other areas of neurodivergence were more overt during those times of stress. So particularly 1 participant in the interview who was dyslexic and dyspraxic said that her symptoms of dyspraxia only ever really appeared when she was stressed or tired, when she walked into things and people and dropped things. But if you think about long days, night shifts, shift work in general, that can have a real effect on anybody in the medical profession. So effects of neurodivergence in the university type settings. Again, lack of confidence was a real big issue. There was very few people that didn't think that it affected them at all. Planning and structuring assignments, procrastination was again a big issue. I have to admit that I've got a map of procrastination on my wall, and I'm looking at the moment because I'm terrible at that kind of thing. Some enjoyed writing exams, but not many, but most of them found exams were difficult. They found managing their workload difficult. Some disliked giving presentations. Maths was something that a lot of the participants, both in the survey and in the interviews, identified as being an issue. And some just avoided formal learning once they got through their initial pre-registration programme entirely. Reasonable adjustments in university, they were very variable. Some got none, whereas others got lots. Reasonable adjustments will depend on individual recommendations from the person diagnosing the condition, or such as the educational psychologist or a specialist teacher. But how these were interpreted or put into place was not consistent. Some interviewees discussed how they'd struggled to be allowed to record lectures or access lecture notes prior to sessions where others didn't. Software was available through things like disabled student allowance, but it wasn't always used, especially if training wasn't given and they didn't see the benefit of it. Particularly if you're struggling anyway, to then add to having to learn another skill or another piece of kit is difficult. And also accessing those tutorials is another commitment that you've got to remember, engage with. Reasonable adjustments were also dependent a bit on recognition and disclosure. And often the participants weren't actually picked up as being neurodivergent until late down in along their pathways, particularly when they were failing. There were also interview participants who discussed wanting to prove that they could achieve without support, and that generally didn't go well in a number of those cases. Post-registration students, so those who are actually trying to work full-time and access part-time courses, often found access to additional support very difficult and an additional burden. And as already previously discussed, you need to have the executive skills and the organisation to be able to access some of those tutorials, extra tutorial support. So taking it forward into practice, again, small numbers felt that it didn't affect them in practice. And then we have a variety of effects in practice. And as we have got quite a range of areas of neurodivergent, you'll see that there are different things that they found difficult. But being able to pronounce terminology, spell terminology, remember the correct words to use, time management, and again, for the number of students that we had that identified as being dyscalculic, drug calculations were, or not just students, staff that were dyscalculic, the number that found drug calculations difficult was massive. What else was found difficult was that changing of placements. So going into a placement, getting used to the way that the placement ran, often having to have those difficult discussions and identifying whether or not you want to disclose or that you are neurodivergent. And what I found from my research is people only do that if they feel comfortable. And that they feel safe and that there is a payoff. So if it's not worth doing it, they will not do it. Or if they go into an area and find that they don't feel that people are going to take it well or be kind to them, or it be a benefit to them, they are not going to disclose, particularly if they've had a difficult experience in the past. So if you're a student having to do that every 4 to 6 weeks, or every time you move placement, you're having to make those decisions, those emotional difficulties, that then becomes another additional burden. Reasonable adjustments in practice. The major thing that came up, as you can see from this picture, is none. 191 of the respondents in the survey said that they didn't get any reasonable adjustments at all. Some because they didn't disclose, and some because they were just not offered any or able to access any. Extra time was identified by 2 to write up notes. Support and understanding. Managers and colleagues and practice assessors were seen as the key people when accessing reasonable adjustments, or even whether to disclose that they were neurodivergent. Successful placements for students were seen where practice assessors were able to adapt their teaching style to suit the students' learning and the reasonable adjustments. These practitioners, either students or registered staff, have got huge numbers of strategies that they put in place. One of the key things that was seen, particularly in practice or even in universities, was using documents as guides, so using templates. Not being able to understand or work out a structure is quite a big thing for a lot of the neurodivergent students. Having something to just look at and just make sure that you can see how it should be laid out was really helpful. We had people that were memorising what they were going to say and rehearsing over and over again. So if you had to do handover, rehearsing over and over again before you go into handover. Or if you've got to read out or do a presentation, trying to remember what you've got to say, so you don't have to read it out off a script. That's not great if you haven't got a great working memory. Finding quiet places to go and write was a strategy by lots. What I've found is that, and I'm sure that lots of people would identify with this, trying those distractions from lots of people being around. Students tell me that they will write down what's being said behind them rather than what they're thinking, if they're not careful. Assistive technologies weren't used by huge numbers, but what we did know was that people worked harder. They worked harder both in theory and practice just to make sure that they were doing things as best that they possibly can. They had to read more, they had to do more work, and that's incredibly tiring, either through masking or actually just physically just having to feel that they needed to overcompensate and do better than perhaps some of their peers. And double check absolutely everything. Even those that didn't worry so much about maths calculations, they would double, triple, quadruple check those drug calculations just to make sure that their patients were safe. For some practitioners, they were able to do things like take regular breaks or even change shifts. So they had shorter shifts, or they arranged their lunch breaks so that they were able to take a little bit of a longer lunch break, work a little bit later. Those particular participants are often sort of in more senior posts and were therefore able to do that. Use of notebooks and lists, again, was incredibly common. But what the participants felt was that they brought a lot to nursing. They felt that they were very much more empathetic, that they brought the issues that they struggled with all their lives generally, and they brought that empathy in supporting their students, their patients. They felt that they had incredible problem-solving skills. They've had to find ways of working around any issues that they've had. So they thought outside the box, and they looked at things in different ways. I know Alex talked about ADHD not being creative, but they learned creative ways of doing things. And they showed huge amounts of resilience to get to where they were in lots of cases. So some recommendations. We're getting there, I think, with wider recognition and a greater understanding of neurodiversity, both in university and practice settings, but we're nowhere near that yet. There's still, unfortunately, a stigma associated with areas of neurodiversity. And that then means that people are less likely to disclose and get support. And we have ways that do not help them along the way. So greater understanding of support that is available, both for those that might access the support, but also to those that might support those individuals. So if people don't know that there is support out there, they're not going to access it. And then also enabling people to access that support within their normal time, so that it's not an additional burden on top. More consistent approaches to reasonable adjustments. Yes, we have to have individual reasonable adjustments, but you've got students with similar profiles. One university is saying you can have this, another university is saying you can't. One area of practice is saying that you can use your phone in practice as a, for example, as a an alarm, or to check how to pronounce a word, have your BNF on it, all of those kind of things. Another area that sometimes in the same trust will say, no, you can't. And that's just not fair or right. We also need to make sure that people are able to use their compensatory strategies. Some of the participants, when they went to go for study skills support, were basically told that the strategies that they had used for years shouldn't be using anymore, had to throw those out of the window, and they had to do it this way. And that's not helpful. It's undermining, it reduces confidence, particularly if you've got somebody who, by that stage, I think one of my participants was a PhD student, to then say, well, all the strategies you've developed to get to this stage are now redundant. You need to try using this way. So we need to think as those that support students, working with them. And I'm sure many good people will do that, but it doesn't always happen. And then thinking about inclusive practices. So I could do a whole session on universal design for learning, but enabling people to access learning in different ways, engaging in assessments in different ways, so that people can access learn the best way that they can, and demonstrate to us the learning in a way that suits them. And the same with things like in class. I think Alex was talking about sitting in class being incredibly painful for some. I have got student groups where at least half the group is neurodivergent. We've got very small numbers, but we have got one group in particular where I think 9 out of 15 are neurodivergent in one way. We need rest breaks. A 2-hour lesson's not going to work. They're up and down like yo-yos. And that's fine. We just need to engage with that. And I've had a student knitting in my classroom to stop her crying over my maths teaching. It helped her, didn't bother me. It's just being able to support the students the best way that they can. So there's some references and some further reading for you. Thank you.
Thank you, Rachel. That was a really great overview of your research findings there. And I think some of the things that struck me included things like the idea of your participants who felt they couldn't go back into clinical practice after receiving a neurodivergent label during their career, during their PhD. I think that's quite telling and fits in with the tragedy narrative concept. And drawing from your later parts on reasonable adjustments actually brings us really nicely into our final talk from Mary, who's going to be focusing on giving us a framework on which to hang reasonable adjustments for autistic learners from med student all the way through to registrar and continued learning consultant level. So I will now hand over to Mary.
Thanks, Seb. Let's see if I can share the slides. Is that coming up nicely? Is that coming up? Can you see the slide?
Looks good.
Great. Okay, thank you. Right. So in the interest of time, I'm going to scoot through a lot of this. Happy to share the slides. I'm hoping that you'll hear a lot more about this framework, our autistic space framework. And the thing is, as in ADI, we tend to get 3 different kinds of emails, right? First, most common from doctors, how can I join? Next, most common is probably, how can I find an autistic doctor? And then the third group is from educators and supervisors with a neurodivergent trainee, how can I help? I have no idea where to start. And I think that's why the framework that we have is quite useful. Now, where it came from, whoops, the daisies, how do we, hang on, give me a minute.
Mary, can you put it onto slideshow, do you think?
Oh, is that not what I've done? I've put up, I see. Have I done the wrong one?
That's brilliant.
That's better. Okay, super. Whoops, the daisies, let me go back. Sorry. Right. Okay. So this is where we started. This is basically Autistic Space. It's a framework that we've developed to meet the needs of autistic patients in healthcare. And this is currently in production with the British Journal of Hospital Medicine. And as we look at the needs of neurodivergent learners in medicine, really they're very similar to the needs of patients. So we've kind of just adapted this framework, and hopefully you'll find it helpful. Basically, it's based on the concept of autistic space. For any of you who are autistic, you'll recognize the concept of autistic space because it's something that's really precious, I think, to us really in the autistic community. Because what it means is, sorry, I'm just getting rid of something on the phone. What it means is places and spaces where autistic needs are prioritized. And it really is just so lovely to go into somewhere that is autistic space, where we can just be ourselves, we can be comfortable and confident that our sensory needs are going to be accepted, that our way of communication is going to be just, understood. It really is fabulous. So anyway, that's the framework that we're using. That's the graphic. It's designed by an autistic graphic designer, Amanda McGuinness, and SPACE stands for sensory needs, predictability, acceptance, communication, and empathy. And you'll see 3 other domains there where the concepts are useful: physical space, processing space, and emotional space. We think this is going to be a game changer really in terms of being able to meet the needs of autistic patients and also meet the needs of autistic people. And indeed, we think that this is probably, even though it's autism specific, we think it's probably more, applicable potentially more widely in terms of neurodivergent learners in general. At least some of it is. Oops, the daisies, and I'm still stuck. Hang on. Really not doing well with technology. Here we go. Yeah. So sensory stuff. Not just because it's the first letter in the acronym, it's actually the most important thing in my view for autistic people, because it underlies everything to do with our experience as autistic people. So almost all autistic people, I think all autistic people really do have sensory sensitivities that are genuinely different to the experience of the world you'll have if you're not autistic. People can be hyper or hyposensitive to any sensory modality, and you can get a really complex mix, I think, which leads to a lot of sensory seeking behavior, a lot of sensory avoidant behavior. But really important to understand is that the sensory environment can very significantly impact our ability to focus, to think, to communicate. And it's everything from fabrics to posture and balance to, as well as the usual light, sound, smell, taste, touch. And things like lecture theatres, sensory nightmare. You know, if you're happy being squashed in the middle of a conference, say, where, you know, chairs are tightly packed together, you're probably not autistic. You'll find us down the back trying to get a bit of space, because touch is really tough. You know, lots of clinical teaching settings, fluorescent lights, particularly flashing lights, you know, flickering lights, really, really difficult. And the thing is, if you're not autistic, they're really hard to understand, but they are genuinely just as real as physical barriers. And as I've said, will exacerbate all other challenges. Here's an example. Some of you may have seen this one before. This is an orthopedic colleague of mine. Oh, loves talking about, asking me about autism. And, you know, for example, and this was outside our one of our theatres. You know, and he said, I'm struggling to, I had to say, I'm struggling to focus on the chat because of the noise from the air handling unit above our heads. I have to actively focus, whereas he just filters it out. He goes, what noise? And that photo was taken 75 decibels, which is somewhere between a Hoover and heavy traffic. That was taken after he'd gone. So that was, you know, no voices in there. Light is another one that I'm really, really sensitive to. So your average clinical room, again, some of you will have seen this before, but that's what it looks like to me sometimes. And again, not saying that my visual processing is distorted to the point where I can't see things, but I recognize that photo in a way that you might recognize a caricature, for example, you know, and working on days like that, they're really, really tough, you know. And the thing about sensory issues is it can very quickly lead to sensory overload, because all the various sensory inputs are all cumulative. And then you end up in a situation where someone's unable to think clearly, unable to talk, and unable to communicate. And as I'll talk about in a minute, really the only way to deal with that is to just wait, not add any further input, such as talking, you know, or trying to pull somebody out of that stage. It's a bit like when a computer crashes. All you can do is wait, really. Turn off lights, avoid conversation in a noisy environment. Really important if you're giving feedback to a trainee and you're doing it in a busy environment. Really, really difficult. Smells, very common, you know, very common trigger for a lot of us. Touch is so aversive for so many autistic people, just even casual touch, you know, and like if you casually touch somebody maybe who's, you know, struggling to accept some negative feedback and they just flinch, because that's our natural reaction, that's not the message we want to give. So it's really difficult to be in that situation. Clothing choices, the reason I chose anesthesia was I could wear scrubs all the time. It really, really matters. Things like having conversations can be very difficult when we might not necessarily know how we feel inside. Alexithymia is just not being aware of our emotions and struggling to, you know, describe them. And sometimes this can be seen as a, you know, a failure to engage, or, you know, a refusal to answer. It's actually not. We just often don't know how we're feeling. And again, then there's our body language, which can be very different as well. Predictability. I cannot tell you how important predictability is, and just the degree of anxiety that unpredictability or unexpected changes actually cause. Absolute nightmare. So things that you can do are, you know, having timetables and rotations as far in advance as possible, and minimize changes to location. I mean, we've had a few of our members who have had, as a reasonable adjustment, not changing hospitals. Makes a massive difference. You know, if somebody can work, people can learn so much better in a familiar environment. Photographs are great. Most of us are face blind. Acceptance is just so important. I mean, I could spend the entire time talking just about this one, but what I will say is that a neurodiversity affirmative approach is absolutely the way to go in terms of maximizing the performance of your trainees, and also the mental health aspect. I mean, you know, seeing, as Seb said earlier, seeing autism as a disorder being associated with suicidality, I mean, that's just shocking. I also know that for myself on a personal level. I have 2 neurodivergent kids. One grew up in the, you know, core deficit pathology paradigm, horrendous mental health outcomes. The younger one grew up in the neurodiversity paradigm, happy as a clam. you know, the most obviously autistic of the lot of us, but I'm not worried about mental health issues there because, you know, he's confidently autistic. And that's because of that neurodiversity affirmative approach. Really, really important. And that means knowing about stimming, for example, knowing about things like monotropism, the way that we focus attention, you know, really important. And then alongside that is the executive functioning challenges that we do, you know, we do struggle with, and knowing them and accepting them and finding workarounds, and indeed having a good sense of humor, makes such a massive difference to how people feel about themselves. And then if people feel good about themselves, then people perform better. And it's just so much easier if the way we are in this world is accepted as valid and valuable. And then, you know, acceptance then also puts the responsibility on you know, educators and supervisors and, you know, those who design curriculum, because, you know, expecting us to function in an environment that is designed for the neurotypical majority, you know, really it's not the way to get the best out of neurodivergent people. And it's just so important that that's recognized. Communication, again, we could spend the whole time talking about communication, but the one thing I will say is that if you're not autistic, communicating with autistic people is not intuitive. You have to really think about it. Now, the corollary to that is, if it is intuitive, maybe consider looking at some of the screening tools yourself. If you find you fit, you know, if you find the fit, maybe consider joining us or one of the other neurodivergent groups. But anyway, speech is unreliable for autistic people under times of pressure. Even those of us who are generally and usually fluent and articulate can lose complete access to speech, and that often happens in a stressful environment, often clinical exams, and again particularly OSCEs and practical exams. We've a member who describes failing every second exam consecutively, so goes into a new exam, fails the exam, comes back to do the repeats, and because it's no longer unfamiliar, flies through and does really well. You know, and that's not unusual. It's really not. Language use is very particular in terms of autistic people. We tend to communicate in particular ways, and we'll interpret things really, really literally. Don't get hints, you know. I'm going to skip over this one, but that's some data from our Barriers to Healthcare paper. And it's just about needing to give the whole story, not leaving anything out, but recognizing that as supervisors, you can scaffold those conversations. It's fine to say to an autistic person, okay, you've answered that question sufficiently, let's move on. But definitely avoid hints, avoid metaphors, so important. And just check, you know, check understanding. Make sure that feedback is unambiguous. People often couch potentially negative feedback in, you know, woolly sort of language, maybe to soften the blow. We miss those messages. So it's really important to be very, very blunt, almost to the point that it feels rude if you're not autistic. That's how blunt you have to be if you want to get a message across to an autistic person. Empathy. The most damaging myth about autistic people is that we do not feel empathy. It's complete nonsense. I wish I had half an hour to talk about this. Just know that it's not true. And there you go. It's absolutely not true. If you want to read more about it, that editorial by Sue Fletcher Watson is a really good read. That's the graphic again. The physical space, yeah, like we do need more space. Avoid close proximity, avoid casual touch, particularly allow people who struggle in difficult, crowded lecture rooms to learn online. I mean, the pandemic was super for many of our members who really were able to engage with learning in a way that they just couldn't in the physical space. Processing space really is processing time. And that is something that's really common with autistic people, indeed neurodivergent people more widely. And it just means needing extra time to process new information. So responding to questions, making decisions, accepting suggestions, all of that, it can all just take that little bit longer. And if you just wait, it can make things so much easier. And recognizing all of these things means that, you know, what commonly happens is situations that can potentially be fraught just get escalated really, really quickly and often unnecessarily. And as I said earlier, if you have somebody who is upset or distressed, you know, for whatever reason, the way to manage that is to just ensure they're safe, first of all, and then just minimize all sensory input, all communication, absolutely no unnecessary words. Silence, restorative solitude is what's needed. In conclusion, hopefully the autistic space you might find helpful in terms of just having a framework to start with, because often people say, I don't even know where to start. Autism is just so nebulous. We'll be doing some workshops on this. Do look at your own positionality, you know, and consider whether you have so-called communication deficits with your autistic learners. Autonomy is important, and particularly around disclosure, and we might come back to that in the questions. But more than anything, a neurodiversity affirmative approach for the optimum outcome is what we need to be aiming for. And I think that's it. Yeah. Okay, that's me done.
Thank you, Mary. Obviously, I'm a little biased, having helped you to co-produce that, but it really is a fabulous framework. And thank you for taking us through how we can apply that to medical education as well. If people don't mind, I think we're running about 20 minutes behind at the moment because we had some really fabulous in-depth talks there. So I think the plan at the moment is to skip the break, although I would remind people that whilst we're sitting still, we can't see any of the attendees. So if you want to get up, move around, jog on the spot, whatever you fancy doing, we can't see it. So don't worry about us hearing or seeing anything. But I think it would probably be a good idea for us to skip over the break into the panel discussion now, if the panel are happy with that. And if so, I'll hand back over to the Academy to lead on that one.
Okay, thanks, Seb. And as Seb said, if you want to jump up, I feel really bad actually running an event where people find it difficult to sit still, and I'm saying right now just sit still for 2 hours. So feel free to turn your camera off and do some star jumps. I'm going to start at the bottom with a question from Jim Price, and the reason I'm starting with this is I think that you all might have slightly different opinions on this. And the question is, could the panel discuss how reasonable adjustments are defined in law? Which I think might be a very difficult question to answer. So does anybody want to start off with that? Have you got your breath back, Mary? Oh, right, Alex, were you signalling?
I'm happy for anybody else to.
Yeah, well, no, if you're signalling, I picked it up, but you might have just been scratching your nose.
No, we get asked this a lot on the charity, and we work with Access to Work and the other things that are available to some geographical regions, and it's inherently woolly. So there's a difference between going against the 2010 Disabilities Act and reasonable adjustments. It's incredibly common in our experiences for there to be no consequences of not doing any of the reasonable adjustments, even if you've agreed to them, unless they're very, very clear barriers, such as not having a ramp instead of steps, unless you've got a good reason not to, or you've got one of these awful little lifts about 3 miles away around the back of your building by the toilets. So a lot of this comes down to sort of reputational damage rather than, I mean, legally, reasonable adjustments are you have to make a reasonable attempt to move the barriers to access. That's the phrase they all work to services or educational delivery. That's the legal term of reasonable adjustments. There's some really good information on this on the website. Is it with the civil blooming people? I've forgotten their names. This is lack of working memory. The people that do citizens advice. That's what I'm looking for. So that's the idea, is that anything where it's not about making everybody, it's not about equality, it's about equity. Equity of access, equity of service, equity of delivery. So if there's a barrier that can be relatively simply physically or structurally removed to give you a similar chance of success, it's not about, you know, saying, oh, go on, Alex, you can have 100% in that. It's about, have I got a chance of success within the framework of what is necessary for, in this case, to be a doctor, then they are legally obliged to do it. Enforcing that, almost impossible. That's my view. I'm really happy for anybody to say, what an idiot, he's completely wrong.
I can add a little to that, although I completely agree with everything you said. One thing that I would add that I think is a question I'm asked quite a lot, particularly with NHS-based employers, sits around, but aren't we giving them an unfair advantage? I hear that one all too often. Oh, but isn't that a bit of an easy ride? And the Quality and Human Rights Commission actually has some really fabulously clear, autistic, I like clear, has some very clear guidance on this, which essentially lays out that actually it's illegal to discriminate or to not adjust, but it's not illegal to over adjust or to adjust in a way that is externally looks advantageous. Because essentially that would dissuade people from removing barriers. And as Mary's talk really nicely outlined, a lot of the barriers are just completely invisible to people who aren't experiencing them. So it's a nice piece of addition from the Equality and Human Rights Commission on top of what's available on the Citizens Advice website.
Go for it, Rachel.
I entirely agree with everything that everybody's saying. I come from an island who doesn't have any legislation as yet. So there's no law here about discrimination at all related to disability. It's coming. I've been stood there campaigning for it for 10 years, I think. It should be here in October. So they're just starting to put the training in. But yeah, there's nothing here to back up at all.
Mary.
I'm not going to talk about the legal aspect of things because I haven't looked at that in a while. But what I will say is that most of the really important reasonable adjustments are around understanding. And particularly around understanding our way of communicating. That costs nothing. All it costs, all it takes is, a little bit of time invested in just learning a little bit more about our world. I mean, the College of Psychiatrists have a lovely report, and it's, it starts with the first recommendation, which is becoming familiar with the autistic world, and it really makes all the difference, because particularly if you have a situation like, for example, delivering feedback and somebody, there's an unexpected response. If you can understand how that has happened, if you're sort of able to, look at that through a neurodivergent or through an autistic lens, things look very, very different when you can do that. And just understanding that makes all the difference. That's probably the one thing, as well as the sensory stuff and predictability issues, that people really, really need. It's not about expensive technology. It's not about, things that cost money. It's just understanding mostly.
Okay,
just one other point is that often people don't want to help but don't know what to do, and we all enjoy doing our jobs well and helping our colleagues to do well. So once people know what to do, people are usually really happy to do that, especially when they see that it works.
Thank you all very much indeed. I see that Claire's popped up. Claire, do you want to field the questions?
Yes, certainly, happy to. Kerry has put in the chat asking about alternative methods of assessment. That's possibly something for Seb and Mary to start with.
Yeah, I mean, so obviously a broad question. Yeah, so in terms of alternate kind of modes or methods of assessment, that is of course tricky because it requires approval at kind of curricular level and exam board level, depending on the institution. There are lots of ways we can certainly adjust pre-existing assessment methods. So I recently wrote our guidance on this actually for our postgraduate talk courses at Brighton and Sussex. So there's lots of things. I mean, most people are familiar with the idea of give everyone some extra time in an exam, very one size fits all. I think they're superfluous, but lots of people say 20%, 25, 15, and there's a bit of a postcode lottery in there. But there, other things kind of, okay, we're sitting in an exam. Have we considered the sensory environment in that exam hall? Are they in a room with lots of other people coughing and sneezing and distracted? Things like even if they have to be sat in that room, can they be sat in a quiet corner of that room? Kind of walls on two sides prevent sensory distractions, things like that. Sometimes people might find scribes helpful and things, you know, and having their own rooms to do things. I've recently had a really fabulous dissertation supervisee do her dissertation on the experiences of medical students with ADHD. And one of the interesting findings actually that she found there was that something that her participants were really longing for was support with keeping on track with deadlines. So when it came to essays, they weren't as fussed about the standard adjustments the university were providing around writing, which was more dyslexia inclined. But what they really longed for was someone to send an email out to the cohort regularly going, by the way, you're 2 weeks away from the deadline. By the way, you're a week away. And they use the phrase that they like to be held accountable for that to keep them on track and keep them focused. And then for things like verbal exams, trying to ask short questions, one question at a time. Jackie and I had a chat before we started about different stages of different questions, which is really interesting. They're kind of keeping a focus question. So you might say, what did you hear when you listened to their chest? Instead of, what did you hear when you listened to their chest and what does that make you think of? They'll answer the second one, probably not the first one. Or vice versa. So separating questions out into chunks can be helpful. And if learners are becoming flustered in Vivas or practical exams like that, then drawing on some of what Mary was saying around not continuing to try and rephrase things in lots of different ways. So minimizing sensory input and verbal input as best as possible to allow them to catch up. And there's nothing wrong with saying, you need a second, are you processing? You know, a quick clarification rather than putting more and more info in for them to process. There's obviously millions of ways to adapt assessments, but I think those are a few tips and tricks that I use across various modalities.
Thank you, Seb. Would anybody else like to add to this? Rachel? Oh, sorry, Mary. Sorry.
Just to add that, no, I totally agree with everything that Seb said there. A couple of things that particularly come to mind would be practical exams and OSCEs. And just the thing about particularly being autistic, we don't filter out environmental cues. So commonly in an OSCE, you can maybe have a simulated situation that actually, when you're filtering nothing, looks very, very different from the reality if you had a real patient there. And autistic learners tend to really struggle. So an examiner who understands that and can tell people what to ignore and what to pay attention to, or can even spot when, like, you know, it can spot when somebody has misunderstood the question or has answered a question in a way that's particularly literal. You know, just being able to recognize that and accommodate in the session, absolutely invaluable for our members, I think.
Thank you. Rachel, I think you had your hand up as well.
I've got a master's programme, albeit a post-grad, post-qualifying programme, where we do have alternative assessments. So potentially people could do presentations instead of essays. I've got, like today I was doing research presentations. They were able to pre-record rather than having to stand up in front of the class, because for some that's utterly terrifying and they can't read off the screen particularly well. So we've got lots of ways, as long as they're meeting the outcomes, I've built into the programme as part of validation, alternative options. And that went down really, really well at validation and was commended. So it is doable.
Wonderful. Thank you. Alex.
I've just seen the comment from Jake on the chat, which is exactly what I was going to say, which is ask them. That's the ADHD answer, really. And we won't know because we don't do metacognition very well. We don't pay attention, including to what we pay attention to. So a way to deal with that in a tutorial is to have a look at some of the successes from past events or past learning and split them into positive and negative successes. A lot of us learn through fear and aggression because, you know, we're going to get told off. So looking for strengths that were positive and sorting out what those processes were and what worked can be a really great individualized way to find out. That's also true of adults, you know, staff and everybody, is to figure out the way you work as an individual.
Thank you. One other question for the whole of the panel. A question here from Andrew. So how does hyper-empathy balance with the direct approach in neurodiversity? Would anyone like to? It's in the Q&A chat.
Add something, and to apologise, I don't read social cues, so if I'm talking too much, I don't want to. There's two types of empathy. There's cognitive and affective, as I'm sure you know. I am pretty good at understanding what you're thinking about. Strong cognitive empathy. I don't care. I don't feel what you're feeling. I can understand it. I don't feel it very well. Part of my problem as an adult with ADHD is a form of sociopathy, which lends itself to be a good coach, not a brilliant husband. And it seems there's evidence that effective empathy, this emotional empathy, feeling what you're feeling, is less strong in children with ADHD and really strong in autistic people. And people with both, it depends. And because of the expression, and I'm moving into ADHD now, and someone's gonna have to slap me down, but my reading of it is that the expression of that empathy isn't within social norms, and so isn't read as emotional empathy in ASD, whereas in fact, probably the only group in the population where they have too much empathy that's almost impossible for most people. But in this specific case, that does seem to be the issue. And so that's why.
Thank you.
So I can add some stuff to that. So empathy is obviously a hot topic around some of the autistic stereotypes, particularly. And yeah, hyper empathy is something a lot of us do identify with. I think that we often feel report that we feel empathy much stronger than a lot of our neurotypical or as yet unrecognized neurodivergent colleagues. In terms of the way that would impact with how we communicate, I mean, I would tie in something called the double empathy problem here, based in Damien Milton's work. And that's a theory that refutes some of the earlier studies and research projects that argued that autistic people lacked theory of mind, this idea that we just don't understand how other people work as one of our flaws. Double empathy problem challenged that to basically argue that neither of us know how to walk in the other's shoes. And that the lack of empathy that autistic people were argued to feel was a non-autistic view looking in that we didn't display it in a way that they might have expected. So double empathy reframes it as a two-way issue where autistic people can empathize pretty well with each other and non-autistic pretty well, but neither necessarily get the other intuitively as a bi-directional challenge, rather than being a deficit on the autistic end. And to tie that into the communication side of things, there's a lovely study from Catherine Crompton and her team, which took essentially 3 groups of people, and they wanted to test the double empathy problem from a communication perspective. So they took a group of all autistic participants, a group of all not autistic participants, and a group of mixed, where they alternated one autistic, one not, one autistic, one not. And they played that childhood game where you whisper stuff to the first person and then you test how much accurately got to the end. We know what webinar we're on, so we know which group did the best. It was the autistic group. And actually the worst group, statistically significantly as well, the substantially worst group was the mixed group, as a bi-directional issue in communication. I presume the question was grounded in Mary's slide about being abrupt if you need to interrupt questions. I think that will tie into the difference in communication skills. To some extent, we get each other usually, and we communicate as the title of Catherine Crompton's paper, highly effectively, peer-to-peer, in line with the idea of double empathy.
Thank you, Seb.
Yeah, and if I can come in there to just say something that I'm brain scrambling a little at this stage, so I'm struggling to process, but bear with me because it's important. Autistic people communicate in a particularly blunt way. We often get accused of being rude or aggressive or whatever. And commonly that's because non-autistic people listening will assume that we are feeling the way they would be feeling if they spoke that way, if that makes sense. When actually, that's not the case at all. So I'm just wondering if that's somehow tied into the question in terms of, are you going to really upset somebody by being blunt? No, absolutely not. Be blunt enough that you feel uncomfortable if you want to get that message across to autistic people, but also understand that if an autistic person is appearing rude, aggressive, distressed, angry, whatever, that's quite likely your interpretation, because that's how you would be feeling if you're not autistic and you were acting in the same way, when actually as an autistic person it's completely different. So that's something that we understand amongst ourselves, and is really, really important for that cross neurotype understanding to happen. So I hope that made sense.
Thank you, Mary. Perhaps if the panel don't mind, we'll just ask one more question and then I'll hand back over to Jackie. Is that okay, Jackie? So what do you think about competitive environments being a possible barrier to disclosure and its implications?
I can certainly start us off there. Yeah, if anyone has read any of my research, it's very central to pretty much 10 years worth of outputs for me. There's so many issues with competitive environments. I think, you know, we talk about the toxic environment sometimes, particularly in undergraduate education, and particularly in the UK, where the students are, rather than graded, they're ranked against each other. So that, you know, we create an environment where learners need to do better than their peers. And what that does, I think, for neurodivergent learners, that to some extent there's a degree of innocence, particularly those of us on the autistic ADHD side of things. I think we try to take other people with an unconditional positive regard, when actually people do try and undercut and get ahead by sabotaging others, and there's an issue there. And I think we're also more prone to maladaptive perfectionism, particularly autistic learners. So, you know, we put our all into everything we do, and a lot of our emotional investment is in our work. So if that's our mindset, or if anyone here is transactionally analytic minded, a be perfect driver, which I think a lot of neurodivergent folks are, then working within that undergraduate system and learning there, where no matter how well you do, no matter how much you try, you always be told 80% amazing, but 40% of people did better than you, so you're only in this decile. It can be really harmful in terms of well-being, but it can also promote maladaptive perfectionism, where you work harder and harder and harder until you burn out, essentially. And I think the only other thing I would bring into this around the competitive environment is that neurodivergent people, particularly again the autistic end, are easy targets, I think, for social exclusion and marginalization, and where social learning becomes so important, and the hidden curriculum in undergraduate studies, so often neurodivergent learners become excluded due to that competitive environment.
Thank you, Seb.
Yeah, and if I can come in there and say that there's a lot of really practical applications to a lot of that for a lot of our members, you know, who get hauled up in front of fitness to practice committees, for example. Things would not be a problem if the exact same thing had been done by a popular member of the team. You know, that happens over and over again. And it's just so tragic. So, you know, if somebody is in difficulty, if there is an incident, first thing to think of, would this be a problem if it was somebody who was popular? You know, and that really does help to reframe things. Yeah, and there's too many of our members losing careers because of that exact issue.
Thank you, Mary. Rachel.
Yeah, I agree, and I think that issue around over-scrutiny, people working to try and prove that they can be better than their peers because they feel that they have to. Because there's that constant thing in the background, they're going to find me out. I'm not as, perhaps you've got that whole perhaps childhood experience and all the social ingrained there of they've had problems or struggled all the way through, and they've had to work harder and harder and harder to get where they are, and there's an awful lot of imposter syndrome in there as well. So there's that constant need to keep going, keep working, and work harder and be better than everybody else. And then you don't have, perhaps you're not at the golf course with everybody else, or you're not engaging with those activities that other peers are doing, and meeting with the people that may help you to progress your career along the way.
Thank you, Rachel. Thank you all very much today. I'm going to hand back over to Jackie now, if that's okay.
Yeah, thank you very much. I have really enjoyed this evening, and just want to thank the panel for such frankness and honesty, and trying to help us stand in your shoes. I don't feel I have in any shape or form. And I'm left, and I'm really glad you picked up that last question, Claire, because I've been really concerned about some of the language of outing. And I'm really concerned that for a profession that is supposed to be caring and compassionate, that we don't recognise when somebody is struggling. And I find it really sad, and I see it all the time, and I've been keeping an eye on the chat if people have seen me fidgeting. And what I'm reading is that although we might be beginning to address neurodiversity, neurodivergence in our higher education institutes, we're not anywhere near in the NHS, and it is dismal, and I hadn't really thought about not changing places, not rotating. As a postgraduate dean, I saw no reason to rotate people, which is interesting, but I was not a popular dean for saying that. That didn't mean to say that they couldn't learn a different specialty, but I didn't see any reason why people had to keep changing hospital. But anyway, so I'm glad you've reinforced my belief. But I always like that. I always like confirmation. So really interesting. I don't know whether you've been able to keep an eye on the chat. I hope that when you've had a little bit of a break, you'll be able to see the chat. I hope we can print it off. There's a lot of interest out there. Somebody has asked whether or not we should have a medical educator support group for individuals with ADHD, and I'm not sure whether we should, and I think that's one for you, Alex. I see no reason why we shouldn't, because we are not the police for educators. So just in terms of closing remarks, I think what the four of you have done, and thanks to Claire and the educator team for putting this on, has opened a number of eyes to the really important contributors in our health service out there, and that we all need to be very sensitive. I think, and I hope, that this is the first of very many discussions and thinking around how we embrace all learners, and that we have environments that's suitable for everybody. And as I say, I've learned a lot. I think everybody joining in has learned a lot, and I think the conversations will keep going.